and this, and then like, when did we even go? I think we like went on, because I knew.
All right, it's 9:01.
Because we came down.
You ready?
I think we get the mainsail off anyway. And we're like,
all right, folks. Thanks for taking your seats.
We gotta get you out sailing with us.
For sure.
Yeah.
I know. I told you I'm game.
It is 9:01, so we're gonna get started. We have a full day for you, full morning, excuse me. But thank you for folks joining online. Let me make this a little bigger. Go. Right. And Jessica, keep me honest if we're having any problems with audio, but we did some tests. I think we're good. That's great. I wonder if there's a way for me to use my, I don't know. All right. Excellent. Good morning. Thanks for joining us. We're still waiting for a couple folks, but I think we are going to get going because we just have a lot to go through. Jessica, if you can go to the next slide. Welcome to the second meeting of the Healthcare Affordability Advisory Task Force. I'm Alex Caldwell. I'm the director of the Center for Healthcare Affordability. And we have a full agenda for you this morning focused on 4 basic objectives. We want to really let this group dig in a little bit to your charter, what governance principles you'd like to be using to inform your deliberations, and we'll bring back another version of a little bit more detail of a roadmap for this group to begin going into recommendations. I wonder if, Ellie, are you seeing the same chat? Because I'm seeing chats like pop up on the big screen. So I just want to make sure that folks can be able to see those, or Jessica. You can see, because Andrew just messaged me, and I want to make sure that folks you can put that. Oh, gotcha.
Alex, I don't know if your microphone is making a difference.
People can't hear?
Well, we can hear you, but it's not really.
Yes. Okay. Thank you for noting that. And I will talk about these tiny little silly mics that are in front of you. So these are not amplification mics. They're just for the audio for the public meeting part of this. So I will mention that now, that there are a couple little mics around here. They can capture your voice when it's just sitting there. But I would encourage you to just pick it up if you can when you're speaking, and it just makes it a little bit easier for people to hear. And we can talk about that.
Are they always on?
And they are always on. Okay. So thank you for noting that.
Anything I should?
All right. Okay, so a bunch of things we want to be focusing on today. We want, yeah, and I wonder if there's a sound to go off. We're working on that to allow people to come in without the lobby. Or if Ellie and Kristen maybe can try to work on that if you guys want to sit together. We will have some time coming back to the spending drivers as well. We'll have some data to look through, and we want to begin a discussion of initial priorities. Not that we're going to be selecting priorities today, but that we want you to be thinking about the criteria you may want to be using to select where you want to head next and what you want us to prepare for you. Jessica, can you go to the next slide? Right, so here's your agenda. We do have a break built in the middle. We're going to try to protect that, and we will commit to ending at 11:30. Next slide is the housekeeping elements. We do have bathrooms right out here in the hallway. There's a water fountain. And task force members, we welcome you to get up at any point. There's coffee and breakfast in the back. If you have any problems, if folks listening in online have issues with the technology, we invite you we have people standing by at health.affordability@state.mn.us, the email address for the center. Please do email us if you have questions there. The slides and the recording of this meeting will be available after the meeting. And I just want to remind folks that these are public recorded meetings. And if you are uncomfortable with the tiny little visual that you see here, if you see yourself in that and you don't want to be there, I totally get that. And there are seats up here. Katie's demonstrating for us. You can sit right up here, and you won't be in the the viewpoint of the video. There There is closed captioning available as well. So if you go to the mic, you can, or if you go to your toolbar, if you're listening in online, you can add those captions as well. And there'll also be a transcript of the meeting available with the recording. Thanks, Jessica. Next slide, please. So before we jump to the scope and charter, we have just a couple of introductions of folks that weren't able to join us last time. And we don't have Sheila yet, so maybe we'll come back to her, but I wanted to see if Lois Stevens could start with an intro, and then we have a new member of the centers team. So we'll start with that, and then we'll jump ahead, and you don't even have to press a button, Lois, you just go ahead and speak into it. Yes, thanks for joining.
Okay, hi, I'm Lois Stevens, and when I first heard about the center forming and this task force coming together, I was really excited. I mean, like, I really thought it was a tremendous opportunity to pull together people of talent and experience, and then I could contribute to that in some way. I've had a long history of working in the healthcare field, and actually going all the way back to some of the formations of the original HMOs in the Twin Cities. And, at that time, Minnesota was recognized as a leader, a national leader in healthcare reform and innovations, and pulling people together to come up with inventive new ways of really pulling together the delivery of care, cost of care, and how all of that was financed and paid for. And that's sort of the foundations of those original HMO concepts. And so that really has always appealed to me. I've always tried to work in organizations that were not only just innovative, but were looking at how we organize and deliver care along with how we pay for it. And I think, along the way, the industry has formed and changed and morphed, and we've tried lots of new and different techniques and models. And I think it's where we've come to now is this opportunity to bring together what we know, what we've tried, what we've learned, and apply that in a way that Minnesotans might achieve greater affordability, improved access. And so, I guess what I'm hoping to get out of this participation is that we don't just reinvent the wheel or rehash all the old stuff that we've already done, because we've all been there, we've all done that, and now I think we've got a rare opportunity to pull some thoughts and our intellect and our experience, and perhaps deliver something that really could be unique and valuable for all Minnesotans.
Thank you, Lois. Glad you're here. And we'll come back to Sheila if she does jump in a little bit. We have a new member of our team, which I'm very excited about, Ellie Talsma, who joins us from within the Minnesota Department of Health. So she knows the ropes better than I, and I'm really excited to have her leading our stakeholder engagement. So she'll be a really important partner for for the members in this group. So Ellie, do you want to say a little bit about your
Sure, yeah. So like Alex said, I'm Ellie. I've been with MDH since 2020. That date might ring a bell. I've been in infectious disease primarily. But 3 weeks ago and a day, I officially started working with this center as the stakeholder engagement manager. And I am super excited to be here. I was able to attend the first meeting with you all, and I loved that so many of you called out like that call to action that Lois just sort of alluded to as well, of like, let's not just rehash this, let's do something, right? So I am just very excited to be here. I've already emailed a few of you to meet with you to talk about stakeholder engagement, to just meet you and learn more about your goals for the task force. So if you haven't gotten an email from me yet, be ready, because they will be coming, and I'm excited to get to know all of you better.
Great. We're grateful to have more capacity coming to the center. One, oh, and just in time, hi Sheila, come on in, and I'd love to actually give Sheila a chance to introduce yourself if you wanted to. No, just come on in. Sit down.
Apologies.
No worries.
More construction continues.
Sorry. Sheila, we're glad you're here, and I invited folks to just use these little mics. I know they're, would you like to take a minute, or do you want to introduce yourself? Okay. Want to go now,
Or
or
want me to introduce myself?
yes, that would be great.
2 breaths. There's nothing like meeting people for the first time when you feel
Right.
embarrassed about your behavior.
We're glad you're
So I apologize to all of you. My name is Sheila Kiskadon. I was told to have about a minute to present, and some of you know me because I've had a long career in public service. I started at the county level, worked for a long time with as a consultant with a variety of organizations in Southeast Minnesota, and then got elected to the Senate, where I served for 4 terms. And during that time, we were doing Minnesota Care, and I was on the Health and Human Services Committee. And being from Rochester, I volunteered for that committee. But also, it really fit with my own career path in Health and Human Services. I left the legislature a long time ago, in 2006, went back to my consulting practice, and then was elected to the Olmsted County Board and left after 12 years last December. So I feel like being on this task force is going back to where I was many years ago. And I'm a little bit nervous, candidly, because I haven't been in the completely following the dynamics of the healthcare marketplace. But as a county commissioner, you certainly are aware of some of the consequences to people of what happens with our healthcare system and with public policy. So I'm also, just another kind of personal reflection, I have been until now a UCare member. And so I am having lived experience with the changes in the healthcare marketplace. So I'm really pleased to be with all of you today. And again, I'm kind of embarrassed at my bumpy start, but I hope we'll get past that. Thank you.
Sheila, thank you. I hope that, yes, no embarrassment needed. We're glad that you're here. And we're just, pleased to have this full group. And I know we have maybe one other mic that is going to also come in a minute. But let's jump ahead. And if you can, Jessica, go to the next slide. You'll see at your space, there is your copy of your charter. And that charter you've seen when you were first looking into this task force, and you see at the top, the appointed members will review and update this draft charter. So I'd like to actually take a couple of minutes to just do that. And of course, we can come back to this charter if it's not serving us in a certain way, or if this group needs to do that. But really would love to just be able to move the group forward. And if there are edits to this, additions, et cetera, that you'd like to call out, we want to make sure that we can do that today. And if we want to have further discussions, we can. But the 2 things I wanted to just note for you in here, and then I'm going to open up and ask for any final sort of questions or additions that you'd like to make to this, is 1, the payer and provider task force, which is described as an important complement to this group, will begin convening with recruitment starting next week. And so we'll be looking to you all to help get the word out about that. That group will be convening starting in January of 2026. So we hope to set up applications middle of November and finalize a roster in December. So stay tuned for that. That group will be offering important on-the-ground expertise, implementation expertise on the system dynamics, what it looks like to deliver and finance care from within our payer and provider systems. The second item I want to call out is the co-chair nomination process is also forthcoming. So we'll be looking to you all probably with like an electronic survey or form or something to ask you for nominations, either for yourself or for your peers, to identify 2 co-chairs for this Healthcare Affordability Advisory Task Force. So stay tuned for that, and think today as you're thinking about your principles and just how you want to be sort of what values are going to guide the work. Think about what you most need in that co-chair role. That person will probably need to spend another couple hours preparing with us on meetings, so that group would provide some leadership on behalf of the group and liaising with the center and with MDH. So please be in touch if you have questions about that. We'll send some more information out about it, but those are just two sort of upcoming items I wanted to bring to you. I want to open up and just ask modifications, additions, questions about this charter so that we can take those back, refine this, and finalize.
I know you have said this, but on the recommend actionable solution, that just to the commissioner, is that to the legislature? To whom are we recommending?
The recommendations go to the Center of Health for Healthcare Affordability and to the Commissioner of Health, the Minnesota Department of Health, Commissioner of Health. So the legislature could see those as a secondary audience, but the recommendations are directed to the center and to the Minnesota Department of Health. Should we add that as clarification? Is that what you're suggesting, Marie?
I mean, it's yes, but it's simple enough to
Sure.
know that.
It might be not obvious to others, though.
Yep.
So it may be good to ask the same question. Who are we really reporting to?
Yep, Sheila.
The word affordability shows up throughout, which is our point. While I was reading the charter before I read Billy's great slides, I kept wondering about a glossary and the value of a glossary to define what do we mean when we say affordability and affordable to whom. Everybody could pick this up and say, oh, good, this is about me. I'm going to spend less on healthcare. But we actually have a core audience in terms of the consumer as the primary the stakeholder group that is impacted most significantly by our work, but then there are also layers around that. So then I went and looked at Julie's slides, and I was like, oh, good, there's the definition, which might need a little bit of morphing, but it's still a definition. And I would also say we may want to talk about defining, and maybe this comes in our recommendations, what do we mean by access, and access to what?
Thank you. Yep. Let's maybe go to Lois and then back to Marie.
Yeah. So as I was looking at this, I was wondering if we talk about affordability, will that lead to coverage for all? Is that a goal of this committee? Is coverage for all an objective that we're looking for? Or, what are we at? 3.5 or 4 or 5% uninsured? I mean, by national standards, that's pretty good. So I'm not sure if that's a goal of this group or not.
Thank you. And I'm just noting a couple, I want to call out the definitions, questions, and the goals of the group as maybe being just a question for you all, is whether you want that to live in the charter as sort of the functional document of this group defining your governance, or whether that's something that you want to sort of revisit over time. For example, we're going to talk today about both definitions, principles, and values that will guide your deliberations. I might imagine those not living in a charter like that, because it can be helpful for you all to sort of use them as working documents. So just leaving that out there if people want to respond to that as you want it in the charter, do not. So Marie will come to you in that.
Well, and to that point, and the other, I think the definitional questions might be a little bit more than definitional questions. I mean, I think that there might be a lot in there when we talk about what is affordable, to whom, what, when. I just think that it is a matter of definition, and there's probably quite a bit of policy underlying some of what we might choose to find. So I guess that would argue for maybe someplace else.
Right.
Well,
Okay.
Alex, I have a clarifying question, which is who is this charter for? I mean, because this is a public forum, everybody can access this.
Right. Yeah. I would suggest this group, you think about this charter as your working operational document. And so that's why it's kind of nuts and bolts. You have a co-chair. This is the membership. This is the purpose. It's public, right? So it tells others whether they should pay attention to it or not, and who's going to be in the room and that sort of thing. But in terms of some of the definitional, the goals, definitional questions, the goals of this group, I think it's up to you as to whether you want that to live in here as your operational document. I might suggest it's okay for it to not live here, but, and we'll talk more about it this morning as well, and maybe we have a different opinion after that discussion, but it's, since it's for this group and it's your operational document, I might suggest that those can live outside, but wonder if there's any thought to that, any objection to that. If there's any other questions about the charter, please do get in touch with us. We don't need to have a, that's great feedback for us. So if you have further questions and comments, get in touch. Otherwise, I'm going to move us ahead and move us towards a conversation about the roadmap. Thank you for just offering a little bit of insight into your thinking on that, and stay tuned for those 2 action items coming out of the Provider and Payer Advisory Task Force and the co-chair nomination. Jessica, can you jump ahead to the next slide? Okay, so here's where we are going to dig a little further into the question of how this group is going to do its work and at what time point. So when. So this is what we've been calling the roadmap. And we don't have to make any final decisions today, but I do think that it will be helpful for this group to weigh in and say, like, yes, this is feeling like the right how, and or yes, this is feeling like the right timing, at least to start the work. Because we are planning in December to begin moving us towards, and even at the end of today's conversation, moving us towards thinking about what are going to be the criteria for how this group begins to narrow. Because you could spend a lot of time just looking at the data. What I've heard is this group really wants to dig in and start thinking about action. So I'd like to start thinking about narrowing and prioritization. You can go to the next slide, Jessica. Great. This is what you saw before, and we think this still stands, but what I think we should focus on is numbers 3, 4, and 5. Like, when will you be thinking about narrowing in on different priorities, and how? We're already doing numbers 1 and 2. So we are in the process, and if you can go to the next slide, Jessica, we're doing the work of defining your charter. What is your governance? What are the values and principles that will guide your work? What are the key terms that this group needs to have a shared understanding of? And we will begin a discussion of a policy framework, meaning criteria that will help you think about which areas to dig into and collectively learn more about, and which policy options might fall out of that discussion, might kind of fall to the top. We're also doing the work of, and we will continue for probably a longer time, doing the work of reviewing the landscape. So last time we looked at the impacts of high healthcare spending on consumers, on employers, on the state budget. Today, we're going to begin a discussion of spending drivers. So why is healthcare spending so high? What are those underpinning causes? And we'll continue to do that learning in partnership with other states and with subject matter experts in Minnesota and nationally. And so that work will continue. If you can go to the next slide, Jessica, this is where we want to have some discussion on how you might imagine selecting topics, evaluating your options, and making recommendations. If you go to the next, you click one more time, Jessica. We're proposing that this group consider your work in a sequential set of rounds. So in other words, round 1 might look like fall of this year. So this meeting, next meeting, kind of through the fall, you will be identifying what are the challenges you want to be focusing on, determining criteria for how you'd want to focus. And you may, we're proposing, I want to test this with you, select initial policy topic areas for learning by early 2026. So around the time as the provider and payer group is standing up, you all will be thinking about where you want to focus, so that group can sort of be in complement with that process. You would then spend a couple of months in the spring refining and vetting potential options, technical working groups perhaps, bringing in subject matter experts, guest presentations, and then by the spring, late spring 2026, you would then have an opportunity to refine out of that sort of area of focus that you've decided on, which policy recommendations might you want to refine from within that area. And I want to just note that there's going to be time points that this group will want to be sort of aware of, external milestones, for example, legislative deadlines in the summer, as well as there may be other things like open enrollment, and importantly, HR 1, the federal law that was passed in July of 2025, will be implemented over the course of this group's term. So there are other sort of time points that this group might be sort of wanting to be aware of, even if you're not making recommendations to like feed into that or something, but just being aware of the Rural Health Transformation Program, for example. There's many millions of dollars coming to the state. It'll be important for this group to be sort of tracking on that. It'll be important for the group to be tracking on other sort of external time points. So that this particular model of offering this first round of prioritization would set this group up to be able to make some recommendations in time for, in this case, legislative deadlines. But there may be other deadlines or milestones that you want to call out. The idea then would be that you go through a series of these rounds. Maybe the round 2 is through the next year. Maybe you break off into groups. I don't know that we need to decide all of that yet. But the question for you all is, how does this feel to go through this process of rounds in order to sort of land on some priorities? You can jump to the next slide, and then I'm going to open up for discussion. The timeline that you see on your slides is a look at 2025 to 2026. I think we've maybe got like a lag thing going on like last time. Sorry, Jessica. And what this could look like is you all would be spending time reviewing spending and healthcare spending and spending drivers, reviewing your principles and values, moving into initial priority topic discussions next meeting, asking what are other additional questions that we need to be, or additional data that we need to know about in order to better understand. Yes, we can see it, Jessica, thank you. That we can better understand those priority areas. And then in February through April, if this feels like the right model for you all, you would be diving deeper into those priority topic areas. By May or June, you would then have an opportunity to raise up some policy recommendations. So again, illustrative, this is something to test out with you today. I wanted, my question I think for you all is just, what do you like? What would you change? How does this feel both in terms of the process as well as the when? So the timing, because I think we can edit both. Who wants to start?
And that is you referenced external activities, clearly at the federal level, that will impact the state. There's something built into your process that will help keep us informed about things like this?
That's a great question, Sheila. And basically, yes. So we are highly involved and attuned to, and I'm thinking of Stefan's team at the Health Economics Program, supporting estimates and modeling of, for example, the expiration of the enhanced premium tax credits at the end of this year as part of that federal law. We're weighing in and helping the state sort of anticipate the impacts on Minnesotans. And I expect that some of that may be very relevant to bring to this group. You may have questions about it. I also would note there are other resources that we can be sharing with this group. For example, yesterday, the Senate subcommittee, the state Senate subcommittee came together to look at impacts on the health insurance markets as a result of HR1. That's recorded. We can send that out to you. That has some really rich presentations that sort of build on what we're going to present to you today. There's rich testimony there from employers and from consumers. So yes, like those are a couple of ways that I could imagine we would be supporting you to kind of connect you to that without maybe getting the group sort of, I think we don't want to distract the group from the core work that you should be doing, but it is a healthcare affordability issue that we want to raise up.
Just building on that question and your response, the landscape is always changing when we're in a 2-year process like this, but I think it's worth naming that HR1, the landscape is really, really changing. There's a lot of attention, as Alex just said right now, on what's happening January 1st of next year with the expiration of the enhanced APTCs, and people seeing doubling of their premiums. So we had enough affordability challenges before that, but I think it's worth just noting January 1st of 2027, which is still within our 2 years, the increases that people who are going off of MA and Minnesota Care into the individual market, if they're able to get into the individual market, well, you know, as a percentage increase, those are going to put what we're seeing this January, you know, be a lot worse than doubling for people who currently are on MA and lose MA. So it just, in the sequence that you laid out there, the step 2, which I agree we all have a hunger to kind of jump into the policy, and I do too, to make recommendations, but it seems like we'll need to keep going back to the step 2, which is the landscape analysis, as you're helping us to understand how affordability is about to change for lots of Minnesotans.
Thank you. Yeah, Adam.
Just want to add to that in support of this round idea is, I think it does two things. And one, like Philip said, gives us that opportunity to look at the changing environment and what is it in the moment when we're making this decision. But looking at this as opposed to in 2 years we will get somewhere, this feels like it's going to drive us in a better way to taking steps, and not lock us in as well when things do inevitably change, or we see the impacts of change. So I like what you're selling on the round idea. It seems like it's a good way to operate.
Thank you.
Yeah, I guess my only hesitation is it seems like it presupposes some things. I mean, to the earlier point, I don't know kind of what success would look like for this group. You know, I tried to write down how we would define success. You know, this task force is successful if, and I've got a whole bunch of things, you know, that we reduce the average health insurance premiums, that we reduce the cost of healthcare for public and private payers, that we change the trajectory of healthcare cost growth overall, big goal. You know, but, you know, really probably our goal is to make a recommendation about any of the above. And I think we have to talk about things like, I think we've jumped to some technical tactics around like a specific data point before we talk about kind of our strategic and political reality. You know, if this group makes a recommendation to the commissioner, you know, really, are we successful if we make a set of recommendations and that, you know, technically we've met our goal? I mean, I think we're talking about, you know, by December, we're talking about what already, and we haven't kind of gone through how or why. So I just worry. I said this last time. I mean, the data and understanding it is necessary, but not sufficient to our work. And so I'm afraid we're going to overfixate on the data. And we live in a world where, again, some of us have been doing this for a long time, and it used to be the case that kind of understanding and finding those drivers was kind of like a magical thing. But if you think about it, every payer, every provider, every big purchaser has a overwhelming amount of data and can drill in on it. And I think the question to me is, in a world where all this data exists and you can slice it and dice it every single way, what are the barriers to actually making the change? And I think that's our unique role, is being with such a wealth of experience and so many perspectives and so many years of service here at this table, finally getting under what is stopping people and groups and entities that already have all this data from making that change. And I think that could be our unique contribution. So, I mean, I know I am, weakness of mine is trying to boil the ocean and make everything about everything. And so it's trying to really avoid that. But it just seems like we jumped into some very technical solutions to a problem that I think is going to require some very adaptive kinds of change.
Not sure.
My worry is that we will spend a lot of time, a lot of energy with really great staff support and have no impact. And I'm a little concerned that the system that we're advisory to the commissioner, okay, but the commissioner, then now we start to get into the political reality. So much of what drives healthcare affordability is based on political agendas that are sometimes completely separate from healthcare. And so I'm just sort of expressing a concern. How do we do something that's relevant and really has an impact? And if our focus is simply on the commissioner, do we have a broader mandate or a broader call or a broader purpose? When this was created by the legislature, I'm sure that they were hoping for a broader impact. And so I'm just wondering, maybe we need to start with, some very clear. I'm going to some of what Sheila said. How are we defining some of these things? What are our aspirations in terms of accessibility and affordability? What do we think the state of Minnesota should be seeking? And we should be asking for those policymakers and legislators to align behind those broader visions of what could be in terms of accessibility and affordability and good health outcomes. And I know sometimes those get really pie in the sky, but if you aren't really clear about what you're aiming for, you don't really, you end up with a mishmash anyway. So, and I'm not seeing that focus at all in our discussions. That the materials I've read or the materials today is what are we really trying to achieve in terms of accessibility and affordability or coverage? Question raised.
Well, thank you for the comments. And I do want to note, I want to make maybe one or two more comments if folks wanted to ask additional questions, but I also want to think with you about how to use today's time in discussing our principles, values, and definitions to build towards some of this that I'm hearing, especially from both Sheila and Marie and maybe others. So any other comments and questions before we get to that?
Just on the timeline, everything that's up there looks great. But if it's then iterative for kind of a second set of recommendations, building a little bit on what Sheila was just saying about the kind of situating this in political reality, even if our recommendations are to the commissioner and not to the legislature, it seems like the end of 2026 is probably a better time to be delivering policy recommendations to a commissioner prior to the start of a new legislature than the 2-year point of this body, if I'm thinking through the timeline right, which would be too late for those to be serious proposals of legislature in 2027. Doesn't change anything that's up there, but just thinking about sort of the second round might have to be a little shorter.
Yep.
This might be
Yeah, go ahead.
way beyond scope kind of to I'm like Marie, which is why we probably like each other, because I want to solve world peace. But building on some of the other comments that people have made, I feel like we're talking about affordability kind of in a vacuum without the context of what do we value as a state. Well, you talk about value in healthcare all the time, but that typically means money. But what do we value as a state? And is there a statement of what are our cultural expectations and beliefs in Minnesota that take us back? If the era that Lois described is one that we were all proud of, then do we have a framework for that by which we can then talk about affordability? It sort of feels like cart before the horse if we haven't come to some consensus. And perhaps there is a consensus and I'm just not aware of it. But I think we need some sort of philosophical framework for making a decision about our principles and values when we talk about affordability. That's one thing. And then the second is, I referenced this last time, but I think one of the barriers why we haven't made any progress is because healthcare has become an incredibly lucrative economic engine. And there is a tremendous amount of wealth being extracted from healthcare. And that's sometimes for good. I mean, there's a lot of really great things going on in healthcare because people are investing and extracting wealth. But I think really getting that's a motivator and a driver that could completely undermine everything. So for better or worse. And I think we really need to understand what is the contribution to our state's overall economy from healthcare, and what happens if we try to either tinker with it or radically blow it up, and know who will politically and economically undermine what we're not intentionally necessarily.
Yeah, Adam.
I just want to follow up on some of the what is laid out in our charter about what we are going to do. Talks about making the recommendations and analyzing it. Getting lost in the data is something that I worry about too. I watched that Senate hearing yesterday, and meeting after meeting of all wonderful data, like then it's like, what are we going to do? But I think when we reflect and talk about process and decision making, we need to think about what our charter states and what that role is. And I, as well, will worry about what those next steps are, those actionable. How does that carry through? What's the political support and not? But I think we are called here and we have volunteered to be a part of something that makes strong recommendations based on our values and principles, which I know we'll talk more about. And then the next step has to happen, right? Like somebody else or us or we need to carry forward things past this, but we have a job to do here. And I don't want to fall into a trap I've seen lots of other places fall into, is worrying about those next steps necessarily, not ignoring them, but worrying about them and who is going to. Like we have to do our job so that we or somebody else can take that next step. And we can be drivers for that personally or through our workplaces or whatever we do, but we have to make sure we do that one first with focus and not waste time, spend time, or use up time on those next steps when we don't actually control. So I just want to say that out loud, coming back to our charter, what we're here to do, focusing that time, then whether it's together or separately, however our world operates, we're going to take those next steps and make those things happen.
Good. I think we're set up well to have the next conversation, which is about definitions, principles, values, that kind of that philosophical question that get a little bit of shared understanding. So really appreciate the feedback. And I'm also just hearing not like huge grumblings about a proposed sort of sequential round approach. And so get in touch with you if you have other big concerns about this.
And you all have set up this next conversation really well by talking about the need for, values and principles and the philosophical framework. So, so thank you for that. This part of our conversation is intended to, we talked about the need for definitions and values and principles in our last meeting in September. And so this is intended to help us advance that conversation. We wanted to give you something to react to rather than giving you a blank piece of paper and telling you to invent it yourselves. So this is our attempt to do that, but I hope you'll see that it is very much based on the conversation that we had in September. So let's advance to the next slide. So purpose of what we're trying to do, we're trying to establish this common definition of key concepts. Affordability and what we mean by that is a big one, but we also had a little bit of talk last time about the need to make sure that we are using certain terms really precisely so that we all understand what they mean. And I will be the first to tell you that you will catch me making mistakes about like the difference between cost and expenditures at times, but I think just getting it all out there and being on the same page. So we're going to spend a little bit of time talking about that. And then we will spend a chunk of time talking about values and principles to guide the work of the task force. And, the values are, what do we care about the most? The principles, as we've talked about it, are sort of like, how are we going to put those values into action? What I heard you talking about earlier, Marie, was maybe like taking that down even to like a more granular levels, right? So, sort of like specifically, like what are the outcomes that we would like to see from the system. So we're not going to go all the way there today, but certainly that's a direction that could be a next step from this conversation. So let's go to the next slide. I mean, I wish I could see it on this computer so I wouldn't have to turn around. There it is. This one, it looks like, okay. So affordability. This is, and you can advance, I think, Jessica, this slide is animated for reasons that we didn't intend. So let's just get it all out there. So the starting point for discussion is, number one, a general definition for you all to react to about what affordability means. And what we've sort of got out there as a starting point for discussion is that healthcare affordability means that individuals, families, employers, and governments can pay for needed healthcare without financial hardship and without sacrificing other basic needs or priorities. And then we've defined it a little bit more specifically from the perspective of each sort of constituency group there. So for consumer, it might mean, and this is sort of up for discussion by this group, that out-of-pocket costs, including premiums, are manageable and do not cause people to delay or skip needed care or force trade-offs with essentials. For employers, healthcare premiums don't grow faster than wages or business revenues, making it possible for employers to continue offering coverage sustainably. For government, that public spending on healthcare grows at a sustainable rate that doesn't crowd out other priorities like education, transportation, and other major functions of government. And then from a system-wide perspective, that total healthcare expenditures grow at a sustainable rate and spending delivers value for the money spent. So you'll notice we have not defined what sustainable means here. We can get to that point. We can get to that at another point. One other thing that I want to tell you about defining affordability is that it is possible to take, right now we're just defining it as a concept. It is possible to take that concept and then become very concrete about what we mean. So there is a whole series of work, and some other states have tackled this, that basically says, and you'll see it in the framework for the Affordable Care Act for who qualifies for premium tax credits. Like, well, people at this income level shouldn't have to pay more than X% of their income. So that is sort of carrying this idea of defining affordability and making it very, very granular. We're not doing that today. I did want to point out to you that at the very end of the slide deck, there's a references slide, and one of those references is to an issue brief from the Milbank Memorial Fund that summarizes essentially other states' activities and like exactly how other states have taken those definitions of affordability and made them very granular. So just wanted to make sure that you're aware of that. And then before we open up for discussion, let's go to the next slide about defining some of the other terms. And these are much less philosophical than the definition of affordability, but we heard last time that we wanted to make sure that we are using key terms consistently. So this is our proposition for you, that expenditures or spending is the amount of money that's paid to provide healthcare services to individuals. Depending on the context where we're using this term, that this might also include administrative spending by health plans. That spending is a product of both the price of services and the use of services. The prices are the amount paid per service, which is different from charges down at the bottom, which is the list price of services, which usually doesn't have anything to do with how much gets paid for that service. And utilization is the number of units of service provided. And then finally here, the cost is the amount of resources that it takes to produce a unit of service. And so you can think about this as like a hospital's or a clinic's input costs of actually providing care, which is different than the price that they get paid for providing care. And that one cost is the one that you will see me make the most errors on, because I often tend to use the words cost and spending interchangeably, but I will make every effort to not do that, and you should call me out when I do it. So with that, we have a couple of questions to kind of start off the group discussion. Those are essentially, what questions or comments do you have about these definitions of affordability or the other key concepts? What would you suggest changing about those? And what is missing? So are there other key concepts or definitions that you think are essential for common understanding of the group at this point? Mike.
Sure. I'd like to start by saying, I feel like so conceptually, I'm not sure if we agree that today healthcare is affordable and we're concerned about the growth of healthcare, or if it's unaffordable today. And I get some of that from your definitions of consumers, employers, and the switch from sustainable to, on the one hand, we're talking very much out of pockets, et cetera, and then we go to sustainable when we get to the government. But going back to, are we starting with the belief that it is what it is today and we're just going to try to impact the trajectory? Or are we really tackling the cost of healthcare as a concept or as a part of everybody's budget, whether you're an individual, an employer, or a system?
Yeah, really good thing to point out. So it's not like, yes, so we're trying to affect growth rates, but I think your point is we should also be worried about the level of spending, right? And it's both that matter.
Well, it's both that matter. And to me, just for clarification, I just want to be sure we know what we're talking. Are we talking about the cost? Are we talking about the growth of cost? Because to me, they're two very different concepts.
Do you have an opinion on what we should be talking about? Which of those two?
Sure.
Or is it both?
Feel like the task force is centered around cost, and maybe that's just in the simplicity of the name of the group. I feel like we're talking about cost, and for me, I would like to see us tackle that, because otherwise, it's like so many things in life, right? It feels like as a society we've become numb to the cost until it goes up once a year, or there's some new data, and so for me, that's just important that we really hone in on the aggregate cost.
That.
I would just add my opinion. I think we should be thinking about that healthcare is not affordable today, and in particular data from the health economics program on percentage of Minnesotans who forego care they believe they need, but because they are afraid of the cost, whether it's actually affordable or not, but they're worried about the cost, so they don't get care. And it's, whatever, 25, 30% of Minnesotans, and an astounding number who have chronic diseases that actually need the care. And so I would argue for taking the perspective that the current system is unaffordable in the ways that we want it to be affordable. Yes, we have to worry about the trajectory of costs over time, but I don't think starting with the status quo and saying, look, we reduced spending growth to 5.5% or 4% or whatever, we're taking something that's unaffordable and saying, well, we're not making it worse. I don't think that's success.
Thanks. Laura.
I think while we're in the weeds of definitions, in the defining affordability slide and kind of throughout our conversation, I think we're conflating healthcare and health insurance a lot as the same thing. And I think it's helpful to think about whether the task of this group is fundamentally about health insurance affordability and as the main or only tool to access care, or whether there are potentially policy recommendations that would bring down the cost of care that are outside of those systems, which sounds perhaps like, oh, well, that is the system we have and that's a big ask. But I think there are people who are accessing healthcare pretty regularly, especially things like dental care and mental health care outside of, even if they have insurance. And so I think it's also an important distinction to me because I think, to the
to some of the points that have been made about the amount of wealth that's extracted, I think whether we're centering essentially a business as our policy intervention point or the kind of end goal of people actually being able to fill their healthcare needs feels important to me.
Thank you. Great.
So before I pick at this, I think this is excellent. Thank you very much for doing this and for breaking it down into the different perspectives. That's very helpful. I don't have an answer for this, but I don't also know how we get around putting our opinion on sustainability, because sustainable is then referenced in all the different points of view, and we're kind of defying logic by saying this is unsustainable when in fact it has been sustained for the whole entire time of my career. So I mean, what would make it? What do we think is unsustainable? Now, I mean, I think Matt's point. Look, we could talk about foregone care, which also by definition means it's not sustainable. But set that aside. I think the thing that's also challenging for us is that it has to affordability. I don't think stands alone. A bunch of people here already today talked about accessibility, and so affordability in the absence of accessibility. I could get free bus passes and light rail passes that would be extremely affordable to me, except for I live in Pepin, Wisconsin, and there's no buses or light rail, so, and the reason I think that's important right now is that I think some of the stressors, for reasons, we talked about HR1 and those things are putting incredible stress on the delivery system, which is going to we can make it as affordable as we want, and if it's not accessible, that doesn't mean anything. And then, I mean, I don't think we should do this, but the flip side of a coin that I keep thinking about is, would anybody ever be able to define what is that right level of spending? What would it be? An ideal world, what would it be? But again, that's so contextual. I'll go back to my metaphor-driven person, but a $7,000 bike is pretty unaffordable, but a $7,000 car is affordable, and I think we're going to be faced with that. Examples in healthcare today, is $12,000 a year for GLP-1 drug affordable? How about if that same GLP-1 drug reverses liver disease and reverses heart disease? Is now it affordable? So it's just so contextual, and I don't know how to bring that in a way that I think is important to do, but I'm not exactly sure how.
Yes, well, I love that you're all taking us to a very deep philosophical place. I would, Philip, and then I think we need to move on to the conversation about the values and principles.
Is it possible to go back to the first slide with the 4 boxes?
Yep. Jessica, can we go back 2 slides?
And I can just start to explain. So two quick points. In your discussion about the consumer perspective there, it was very clear that you're thinking about it in this way, but it doesn't really say anything there about the fact that the affordability of the cost for consumers is relative to their income or their wealth or both. And that point was made in our initial discussion about this last time. So it just feels helpful to name that because it's hard to, it's not about the dollars per se, it's about the dollars relative to the person's capacity to spend. And then the second piece, not asking for a change here, I just want to note that the term consumer is I think an unfortunate way of framing people or individuals, which is how you have it, which is much better in the first bullet. It sort of presupposes a context for providing healthcare that is characterized by sort of classic market failures, and the driver of the unsustainable and unaffordable system that we have. So people seems like a better alternative. I think that's probably what it says in the statute for our group. So not asking for a change, but just noting.
Great, thank you. And just to note, for you all if you have additional thoughts after today, please feel free to let us know. But this is great feedback and a great place to start. So I want to move on to our conversation about our values and our principles. So
thank you, Jessica, is about, so the first piece, and what we're going to do is like, spend the next 3 to 4 minutes actually just like telling you what it is that we have put on a page for you to start the discussion. And just like with the definitions, this is just so that you don't have to start with a blank piece of paper and like invent it entirely. So to give you something to react to. So the first piece is the values, which is about, what's important to us about how we do this work. So our starter list is that we will conduct our work transparently, that we will use evidence and data to inform priorities and recommendations, that we will engage and listen to all perspectives while centering consumers or while centering people, that we will consider equity and addressing disparities in cost burden, access, and quality, that we want to collaborate to solve problems across multiple sectors, and that we also want to build on Minnesota's strengths while also seeking examples of approaches that have worked elsewhere and innovate to find new solutions. So I'm going to move on and talk about the sort of the starter list of principles, and then you'll get the opportunity to break up into small groups and sort of come up with reactions and refinements to those. So I've called this slide, Marie, what success looks like, recognizing though that you took us to a more granular place with that. If that's a place where the task force would like to go next with this, we can certainly have that conversation. But some of the draft principles are that, and this comes from the conversation that we had in September, sort of what we heard you all saying about what was important to you about what success looks like. So the first one is that we need to ensure that any system-wide savings that result from this work translate to improved affordability for individual people. So it's not okay just to save the whole system money. We're also about centering consumers and people. At the same time, we need to address total costs. So it's not okay just to shift costs around between different parties. That actions to address costs shouldn't come at the expense of healthcare access and quality. That our actions to address costs must not exacerbate and should improve inequities in healthcare access and affordability. That solutions should be clear about the roles of different stakeholders, so individuals, employers, healthcare providers, health insurers, suppliers, and government, to achieve desired outcomes. And then that we will need to consider both short-term and long-term effects, as well as potential unintended effects. So let's stop there. The next idea, so we would like this group to split up into 3 different groups. We had a preliminary list of splitting up the groups because we want to make sure that sort of like the mix of perspectives is reflected in each group. Do we have a slide with the list?
It should be on there.
Okay. Oh, there it is. Okay. So we have Olivia online. So you all, Ellie, have a recommend. Okay.
I have their number.
Okay. So we're going to sort of pause the online portion of the meeting for those of you that are listening online. We're going to call Jamie and Olivia and sort of like patch them into the small groups to go off and talk about the questions. So group 1 is Andrew, Laura, Matt, and Bree. Group 2 is Jamie, Sheila, Marie, Adam, and Mike. And group 3 is Justin, Philip, Sheila M and Sheila K, Lois, and Olivia. And let's get the questions that we want you all to address up on the screen. Yes, thank you. So we'd like to take about, at this point, it's about like 10 to 12 minutes total to talk about these things. So talk about the 2 lists of the values and principles. You've all got them in hard copy with your handouts. What's your reaction to those lists? What resonates most for you as a group?
what's missing that's important to add? And then if you have time, how would you start to prioritize within those lists? So each of the three groups should select somebody to report out on behalf of the group. We'll reconvene and have a little bit of discussion about the themes from each group's conversation before we take a 10-minute break at about 10:30. Questions? Yeah.
I'm sorry, I don't mean to take up too much of the 10 minutes, but I think Laura asked a really important question that might be unresolved, but I'm wondering, do we have consensus on this question of whether or not we're talking about affordability of coverage or affordability of the system at large, which then leads to more affordable coverage? I think there's always those two things are related, and we need to.
There's a lot to think about there. And I will tell, so one of the ways that I think about it is coverage is never going to be affordable unless underlying care is affordable. And so I have a hard time separating them. So it's not only about the cost of care, but it is also, it's also about the cost of coverage and the benefit structure. So like deductibles and co-payments. And so I think for now, if you guys are okay keeping the conversation about both while recognizing that it comes into play in different ways, is that all right with you? All right. Yeah, Jessica, could you put the groups back up and then we can switch it over to the questions again once we're arranged. Right, so is the plan to just split off into different sections of the room? You, and sorry, I'm not there, so you can get back to me a little bit, but I think employers was another area that we were trying to potentially solve for.
Yes, can you hear us?
There are definitely a lot of employers in Minnesota locally based, but after COVID, I think populations.
Okay, so
Being
let's go back to the slide with the questions for the small group discussion so that we can have those up on the screen while we have it. Thank you.
So perhaps, yes, we focus to impact Minnesotans, but there is potentially spillover, right? Because if they're changing the way they're providing care for their whole population, it's going to go outside of borders, which I think we're definitely okay with. But I think just keeping that in mind when we're tracking data and outcomes, right? It might be where we need more census data driven just to say, are we doing this?
Here we go.
Improve that.
Okay.
Shut up. I mean, it's like, I just feel it's daunting.
All right, so hopefully you all had a good conversation within your small groups and
Olivia, passing the phone back.
selected someone to report out on the conversation on behalf of your group.
Yeah, you think about it.
So let's start with group one, which I think was Matt and Bree and others.
And Laura.
Tell us about your conversation.
So I will try to get us started, but really hope that others will chime in with their recollections because I didn't take great notes. But I think with respect to the values, we had some sort of quasi additions around agreement or belief that change actually is possible, that not getting bogged down by, oh, we've tried this before, or that'll never work, or whatever, but having a commitment that we can change the system. Two, I think there was a interest in sort of beefing up or adding in the notion that we want practical solutions. We don't want to shut down conversation about what should the system be as a whole, but if there are practical, incremental, whatever steps that we can take that are actionable, that we want to include those as well. And then on the principles, or at least what I consider to be with respect to principles, on the first principle, trying to build in the notion that we want to improve affordability for yes, for individuals and families, but also for employers because they pay such a big portion of the sort of end spending. Who's the end entity that's paying for healthcare? A lot of it is employers covering, at least right now anyway, are covering a large portion of that. And so some way of building in that notion as well. And then, and I don't know if this is in the principles or values, but the notion that we can focus on insurance, and that can be limiting to other solutions that are not insurance based. And there's reference to a lot of people in dental, eye care, mental health care. There's a lot of health activity and spending and financing that is not necessarily sort of traditional insurance based.
Right. Yeah, and then I'll add on to that.
Yeah.
We also talked about on the values, bullet 2 is talking about understanding the evidence and the data to inform priorities and recommendations. But then also in the last bullet on that page, it talks about innovating and find new solutions. So there might not always be a ton of data to back up an innovative and new solution. So looking at those. And then, there was one other thing.
In the principles. In the principles, we also talked about how third bullet and second bullet. I know we don't want to shift costs and expenses, but we don't want to limit access for are equity, but or quality, but defined. You know, the house have to can't just limit ourselves by saying we're not going to do this. And still be open if we want to have businesses on actually those strategies.
Great. Group 2, which I think was the group that was over in, no, this was the group over in this corner.
I think we appointed Sheila.
Oh, I think we're,
Is it you?
I think we're
We'll do
good
that.
too.
Okay, sorry.
And I believe got recruited, but I'm going to do a poor job other than to say that a lot of, sounds like we had a very similar conversation to group 1. And I'm going to recruit the other members to speak to this. We had that conversation about the kind of actionability part of our charge and toyed between, you know, practical and feasible recommendations, but also because a recommendation is kind of one of our more significant tools that we have at our disposal. I mean, that's what we do is recommend, that we had to, that there might be parts of kind of education, stakeholder engagement, consensus building broader in the community that would be part of what success looks like for us. We also had a conversation about quite a bit of conversation around the cost shifting and thinking about where the exception to that might be if we were able to shift to more prevention and more things that were better return on investment in healthcare, that might be a shift we would like to see. And then talking about honing in on some of those really big cost drivers. And Sheila, I'm going to turn to you on that, your point on that one for this.
I was recommending that we think about, and this is work for Stefan and his team, to think about prioritizing the known cost drivers so that we don't, it's, who said it? Mike said it, the healthcare is whack-a-mole and we all have our favorite mole. And we all can, you know, point, well, if only they would do this or if only they would do that. And I think it might help to do that, to look at that in a more analytical way. So just for example, at the end of the day, only about 32% of the dollars spent make it to the care of the patient. And there's a lot of intermediaries in between, somewhere between 8 and 14 intermediaries that are peeling money off of that pot on its way to care. And so could we look at them in a hierarchy, Stefan, to look at who has the greatest impact? One example, and this is not my mole, but I'm just saying, is that ultimately about 25% of the dollars get peeled off on the pharmacy track. And so, and maybe that's okay. This isn't a judgment of that. It's just to say we should know that so that we're going after some of the high value, high cost areas when we think about our recommendations.
Okay. And then with Adam or Mike, did we miss anything with that? Okay.
And whack-a-mole was Mike's concept,
yeah.
so I want to acknowledge that.
Group 3. That was
Sure. Similar to one from the last group, we thought that on the principles, adding prevention, upstream interventions, and public health is important, and we didn't see that really called out as part of what we could consider. And that together with that, Olivia was making the point that we have to know that sometimes those kinds of interventions, the results, the outcomes will be seen only in the long term. And so that's kind of a different evaluation process than something where we can make an intervention and see a change in affordability directly. But open it to the other members of the group.
We also agreed that we need to add employers on the principles of how we improve affordability, and employers are really key. And I think it was Olivia made the point that we really do need to track data and look at full outcomes, not just intermediate outcomes in terms of health. We thought that we needed to explore the incentives for healthy living and healthy choices in a way that we see people choosing not to pick up health insurance, and as a result of that, the pool is smaller with those that are more ill. So, what are the incentives for creating health? Not just that was part of our discussion. We we had a discussion that I lost track of about the work by Big Pharma, which Olivia may want to expand on. I don't know if she can come into this conversation right now, but as a pharmacist, she has some direct observations about Big Pharma and its consequences.
And I think it was some of the direct to consumer advertising that they do that creates a demand that then gets translated to the office, the doctor visit, and doctors feel compelled sometimes to prescribe some of these expensive drugs.
Great. Well, it sounds like you all had a great series of conversations, and thank you for sharing those with us. It is time for a break. Let's come back at like 10:40. I will note that that clock over there is a little bit fast. So that gives you about 7 or 8 minutes for a break, and we'll come back and start to dig in, Sheila, to those, like, understanding the cost drivers and prioritizing them. So thank you.
Okay. Yeah.
Now,
Maybe we touch.
yeah.
You can also look at like limits.
Yes,
They're really like carriers will have five. And
You. I'm sure. And
So like you guys are. And a lot of times those narrow networks too. Dave's retired. They're based on where the. And so then you have to figure out, okay.
Jessica, are you able to hear us?
Yes, I am.
Excellent. So we wanted to spend some more time today digging like a level down from the data discussion that we had last time, in part to begin to answer some of these questions about what do we know about what's driving spending, because eventually we will take that and begin to prioritize some of the places that the task force focuses. So Siobhan will take us through like that next level down with data. We're planning to spend about 20 minutes on that part of the conversation. So probably limit questions at this point to clarifying questions, but then we'll transition to like, how do we think about this in terms of how we prioritize? So.
Super. Good morning, everyone. To pick up on the earlier discussion, Marie and Sheila, I think we have to do both. We have to look at data, not because conceptually a lot has changed, but we have to look at data because sort of for the point that Sheila made around how the force is strong in the status quo. And we have to, when we talk about recommendations, when we think about prioritizing, it has to be strongly based on evidence. This is what we learn from other states. It is very, very complicated engaging with the health insurance industry, engaging with the provider industry, and not have the data ready. So I think what I am trying to do is get us to, as Julie said, to the next level of evidence, get you all on the same page, and sort of have the context to help you with the steps of prioritization. Let's see. I have a laptop here that does not connect to the slides. I'm not
sure. Ask Jessica to advance the slides.
Okay, but I also need to move these slides. Julie, can you help me find the?
I was just using the arrow keys to move
arrow keys.
in terms of what I can see.
It won't work for me. Cool. Thank you. So I think the two takeaways from what I want to tell you will be understanding cost drivers, understanding spending drivers is kind of a meaty, complicated task. Context matters. And I'll say more about that in a moment, but I'll start with context by beginning to talk about health insurance coverage. What coverage do we have in Minnesota? How has it been changing over time? And typically, when we think about health insurance coverage, we ask three questions. Who has private coverage in Minnesota or in the US? That's typically the backbone has been the backbone of our healthcare system. How does public program coverage compensate for lack of coverage, eligibility, affordability, or sort of age-based eligibility? And then thirdly, who remains uninsured? And Jessica, next slide, please. And in this slide, we're looking obviously at 2014 and 2023. And there are three major points here. And I'll walk you through it in a second. But private coverage still remains the primary source of coverage for most Minnesotans. In 2023, it's been about 55.6% of Minnesota residents who have private coverage, but it has been declining over time from 2013, about 60, 61, 62%. So number one, private coverage is still important, but it's been declining. Number two, public program coverage. And here we're looking at Medicare, the program for elderly and people with disabilities, and Minnesota healthcare programs in the shape of Medicaid and Minnesota Care, has been more than compensating for this shift away from private coverage. And how do we know that? We know it by looking at the uninsurance rate, and it's been declining from 5.4% right after the introduction of the ACA, which represented a decline in uninsurance at that point, to about 3.8% in 2023. Last week we talked a little about data vintage, and I know 23 is 2 years old. We are in the field right now with the 2025 version of the biennial survey from which we draw some of these data. And so if you get a call to participate in a survey on health access, please take it. Although, like everything gets complicated, it might not be you, it might be somebody in your household. Bear with it. So we're looking at private coverage. We're looking at coverage distribution for two reasons. Number one, the kind of coverage you have relates to, in some ways relates to your healthcare use, but also coverage relates to the influence state policymakers have on the system. To be more specific, it really is not a ton of creative space state policy has. And depending on how you look at it, it's a lot or it's not much. Medicare is largely a program governed by Congress. Medicaid is largely under the control of the state, but it's also in partnership with the federal government. And we're going to talk about this. We've talked about it, and we're going to continue to talk about HR1 in this context. I'm looking at private coverage between fully and self-insured employers, and I can define that term if it's helpful. But self-insured employers are essentially large employers who wish not to be governed by 50 states' insurance market regulations. So that's ERISA governed plans. That's outside of the control of the state legislature as well. The fully insured market is more fundamentally or more directly under the auspices of state oversight and regulation. And most of that really is employer coverage, and we're going to go to employer coverage next. It's maybe not that bleak because the state and policymakers have obviously authority to define oversight of the provider market. So while we're not able to perhaps shape every aspect of coverage, the rules of the market still oftentimes is under the control of the state legislature. Next slide, please. So as I said, most of private coverage is really employer coverage through employers. Just a small portion of employer coverage, just a small portion of private coverage is coverage that we buy individually, people who don't have a connection to an employer or don't get the employer to offer coverage. And that's about, in Minnesota, about 160, 180,000 individual in the individual market who buy it either through MNsure or directly from health insurance carriers. So looking at employer coverage is really important. This is a really busy chart, and I don't know how important it is that we look at all the details. But essentially, when we think about employer coverage, we ask which employer offer coverage. Within those employers, which employees are eligible for that coverage. Among those, who end up enrolling in that coverage. And again, just a few takeaways from this slide. The rate of establishments offering coverage has been pretty steady over time in Minnesota. The degree to which employees within those establishments are eligible for coverage has also been fairly steady over time. Where we do see a change, and you have the helpful circles here, and thank you for Mathematica with helping with those slides, is that fewer employees in firms that offer coverage end up choosing to enroll in coverage. And I don't know that we have a really robust understanding of why that happens. But I think it is fair to say priorities in spending, the cost of coverage, the value that individuals perceive in the coverage that they spend more and more for, perhaps the declining benefit must be contributing factors to this decline.
Question about,
Go ahead.
that's what you mean by take up?
Take up is,
those who are eligible and they choose.
that's right.
So that's gone down.
Yeah.
Which suggests that even employees who have access to insurance are finding it unaffordable.
It's hard to say whether they're finding it unaffordable. They're making the active decision to walk away from that offer.
They may have coverage through a spouse.
Well, and I'm wondering with dependents and being able to stay on plans until 26 now rather than having to be in school or things like that, if that plays into how many people coming out of college or school aren't taking their employer's plan because they're still covered on their parents.
So there is, the focus of this analysis is on employees. So I think it does not extend to dependents, but yes, that's an important
Or how many
point.
are on their spouse's plan or
Right.
like that.
It's a really important question to ask, to what extent dual offer rates have played a role. But in order for us to see lower take up, because people have more dual offers, that would presuppose that more individuals are working for an employer having an offer of coverage. And I'm not sure that these data seem to indicate that. But I think the questions that you're all raising are really important ones. Household decisions, decisions about value, choices, the complexity of the enrollment process. You know, I mean, we think of people as consumers. We think of them as market participants, as economists might say, utility maximizing individuals. I'm an economist. I choose my coverage on the very last day of open enrollment in the last minute because I don't love the process either. So I think complexity, cost, benefits, value, alternative ways of spending money must all be playing into it. The point, though, is employer coverage as the backbone of access to healthcare services has been declining.
Stefan, one more point of clarification. What's the difference between take up and eligible and enrolled?
Well, enrolled is then the multiplication of eligible and take up. So if we look at all individuals who are eligible and enrolled, it's fallen from.
It's a percentage of two.
Right. Yeah. And so because the take up fall, the number of people who were eligible and enrolled fell as well. A busy slide. I'm sorry about that. Next slide, please. As a reminder, despite the changes in coverage, the reorganization of people from private coverage to public coverage, and this is the slide you saw last time, spending growth, the level of spending and the growth of spending has continued over this period. So it's a bit of a constant. Next slide. So, as I said, one of the takeaways from today, and for many of you, it's just a reminder of something that you fundamentally know and have experienced. Context matters. Okay, so half of the population have private coverage, but when we look at spending, we see that more than half of spending is occurred by people with public program coverage. And that's intuitive, of course, if you remember that people with public coverage, to a large extent, are individuals who are old and have high healthcare needs, who have disabilities and have high healthcare needs, or are in long-term care settings, which are expensive. So when we think about spending drivers, we have to take that into account, that and more. And on the right-hand side, context matters also. Where do we spend, where healthcare spending goes is important. And to think about the timeline, I'll move through this really quickly. A third of spending, roughly, goes to hospital care or hospital-based settings. Another third is split between long-term care and what we pay physicians. And then the rest goes to retail prescription drugs. So these are drugs that we pay for or that we get over the counter versus our office administered. Dental services by other professionals, and then things like chemical dependency, the net cost of insurance or profit, and other things that we typically can't account for in data. Yeah.
One quick clarification. And the retail pharmacy spend, would that also include what some people spend on what I'd call personal wellness spend, growing lifestyle spend?
Yes, to an extent. So when we conduct the analysis of healthcare spending, we think about expenditures through the sponsor, the payer, Medicaid, Medicare, the employer, but also what people spend out of pocket. So to the extent that the out-of-pocket spending is captured in the data, it probably captures painkillers and things like that. What it might not capture is wellness visits or supplements.
Yeah.
But it's a really fair and important question.
I have a similar question. So let's say I get a Ozempic for diabetes, and sure, that's once I take Ozempic for weight loss. Is that considered different? Is that considered wellness, or is that considered health?
Well, it depends, and I'm sorry that I'm saying this a lot today. If it's covered under the medical benefit and prescribed, then a portion of it would be, well, it would be expended. I think Ozempic is office administered oftentimes. Sorry, maybe I shouldn't.
It would be retail pharmacy. You would, but it is a prescription.
Yeah, I think if you're there's this term that is emerging, farm to table with a P, PHARM. You buy it yourself, and it's not moving through an insurance benefit, probably be out-of-pocket spending.
But to that, I think we're probably a point worth clarifying. This looks at insurance claims, so that would be your out-of-pocket, like a covered benefit. If it's not covered at all, if I'm getting a weekly massage, that's not going to show up in the out-of-pocket spending. If I decide to self-pay for a drug that is completely not going to be covered, that's not going to show up in these out-of-pocket numbers.
Well, when we collect, when we think of out-of-pocket spending, we look at data reporting where individuals are asked about their spending out of pocket. So some of it is health plan and individual share under insurance system, but some out-of-pocket spending that individuals experience or choose to make through outside of the insurance system would also be captured by total spending. So this is an analysis of total spending. It's not just healthcare claim spending. That's why we include things like profits or the net cost of insurance or school-based spending or public spending.
Two, actually, one is other spending's a pretty big chunk, and you understand what's behind that. And then second, physician seems to be launched. It's a placeholder for something that has dual reimbursement, physicians inside the hospital, so physician services. And then where does ambulatory live?
Yeah, so to start with the second question, different ways of cutting and slicing the data. In this presentation, reimbursement of physicians in hospitals is part of hospital spending, but you can separate professional spending from hospital spending, and sometimes we do that. Your first question was about other spending. Other spending, when we think about healthcare data, oftentimes there's very little data that is collected exclusively for the purposes of policymaking. It is oftentimes a residual to the process of payment or management of delivery of healthcare spending. Other spending in this case, so in other words, we have some detail, we have better detail than many other states, but sometimes it's just unclassified. In this case, what we count in other spending are things like chemical dependency and mental health. I think ED visits fall into this category. The net cost of insurance for profits in the insurance system. And then, as I said, unclassified spending. But if it's helpful, we can break that out and share that after the meeting.
And so just to be clear, physician in this case means outpatient.
Correct.
Messaging standpoint, it might be better to say that and maybe slash physician or something, because otherwise it looks like the physicians themselves are making money.
Well, I think both are true.
Right.
Yeah.
But there's a whole bunch of other players in the ambulatory
world. One reason we have shown it this way is because we think about where spending goes and under whose control the spending is. And as we think about hospital spending and the decisions hospitals make, it extends to the type of service that they provide, the specialties that they deliver, the choices between primary care and specialty care. But absolutely, depending on the question and depending on how we want to prioritize understanding the cost drivers, we do, and this is part of my message, we do want to break this out. We want to get into the details. We want to get way beyond below hospitals. That is, I think, what is necessary to make the point to say this is a driver that we now understand, and there are some different perspectives that we have on whether it's high value, sustainable, in the public interest.
Stefan, let's take until about 11:15 on the data section.
Noted. So next slide, please, Jessica. So many of your questions are engaging in the complexity. And I think it's really important to take some time and think about that, just like it's important earlier to talk about definitions, affordability, cost, spending, price. And I'm going to reiterate that here. As we think about health spending drivers, it is really important to understand not just who has coverage, but also who pays for services, which services are we talking about. Earlier, we had a discussion about levels and growth. understanding which question we answer is really important as we think about cost drivers. And I'll substantiate the importance of these points with a few slides that I will rush through really fast. What are the factors that drive spending? Is it price? Is it volume or quantity? Is it the change in services? All of those are really important and legitimate questions to ask, because when we get to a point and say, prices are rising too high, somebody might say, well, the prices are rising high because we're delivering more complex services. These are not the same. It's not the same market basket. Perhaps prices are rising because inflation, general inflation. Perhaps prices are rising because the way technology is changing over time. Perhaps prices are rising because the market is consolidating. There's market power at work, or input costs rise, to Julie's earlier point. As we think about prices, service mix, volume or quantity, these are starting points to burrow in deeper. For today, and at the end of my slide deck, I have one pragmatic example of spending drivers that we've done for years. But there are ways to approach this pragmatically and say, here's what we understand at a high level. But if we really, I think, want to get to prioritization and make forceful policy recommendations, we have to go much deeper. And then the same is true when we think about quantity and mix of services. To what extent is population demographic or population volume changing and driving healthcare spending? To what extent is it medical technology or the level of therapies that are being supplied? To what extent is volume changing because how healthcare is delivered to patients? Are they still in the hospital for recovery, or are they at home? So it is complex, but it's also really important. And while I'm staying for today at the pragmatic level, I want you to know that the center and our team are working on the kind of burrowing deeper down that I'm arguing is important to understand the different drivers. And so that when we have discussions about prioritizing or discussions about pushing against the status quo and dealing sort of with the desire for corporate healthcare delivery to stay unchanged, that you have strong arguments to push back on questions of value, on questions of impact, on questions of principles as well. Next slide. So I'm going to rush through these slides. Next slide, please. It matters which coverage we're looking at, because within areas of health insurance coverage, per person spending differs based on who's in those buckets of insurance coverage and the type of services these patients need. Next slide, please.
Real quick,
Yeah.
Out of pocket on there, do you mean in conjunction with the other ones, or is that truly someone just paying for their health care?
Is truly out of pocket, but if you look at this number, and every time we show this to our commissioners over time, they look. Jessica, could you go back one slide, please? They look at the number and they say, how can this be right? People have $10,000 deductibles. Well, it is right because it is across the system. Very low to non-existent out-of-pocket spending, more out-of-pocket spending, some out-of-pocket spending, higher out-of-pocket spending. So again, can we break this out by type of coverage? Averages we can. and it's important, and I think we should do that. Next slide. So even within insurance buckets or types of coverage, there is a disproportionate individuals enrolled in the healthcare spending that their care accounts for, right? Families with children account for 60% of Medicaid enrollment, but their spending only accounts for 24%. Why is that? Healthcare for kids is cheap. On the other hand, people with disabilities, their healthcare spending is much more costly because and for elderly, because the care that they need is at a higher level of complexity and they require more care. Next step, next slide. This makes the point again, long-term care services account for more of Medicaid spending, and this is in billion, it's not in 8 at the end. Next slide. I'll skip this other than to say, I'll skip this, but we can talk about it. And I'll skip this too, because I think we're really close to the end. Maybe a second on this slide. When we think about spending drivers across the system, next slide, please. And maybe one more. When we think about spending drivers, I think we don't want to be distracted or over-interpreting year-over-year spending growth, right? Because the levels matter as well. You remember earlier I showed you hospital spending accounts for about 1/3 of total spending. Well, for 4 year spending seems kind of small, relatively speaking, but if you take that in the context of the volume of hospital spending, hospital growth account of total spending growth. And the inverse is true as well if we look at large spending growth, say in in dental or in retail prescription drugs, against a smaller share of total spending at a prescription drug, 12.8%. So rates of growth, but levels really matter as we think about healthcare spending and trends in healthcare spending. So this is, oh, I'm sorry, 2 more slides, please, Jessica. A pragmatic healthcare spending driver analysis, and I think takeaway is, well, what this analysis is take total healthcare spending and it puts it against the context of some known factors. Change in the size of the population and inflation, general inflation. And what this slide tells us is, well, population growth, and that's not a surprise, is not really driving medical spending. Inflation in this analysis that captures a lot of things, admittedly, is an important driver, and then everything else are also drivers of spending. Matt.
Utilization?
Utilization is everything else.
Everything else.
But I know it's really unsatisfying, right? Because what you really want to understand is, okay, within hospital spending, is it specialty services? Which specialty services? Is it, and I'm sorry, Matt, I know you want to follow up. Is it specialty drugs? Is it what we pay nurses? These are the questions that we ultimately need to get to help you prioritize and put a stake into the ground on recommendations.
So going back to our earlier conversation where we were trying to use some definitions. In this slide, is inflation a proxy for price?
To an extent, it always is, right? Because inflation is a measure of changes in the price in the economy. This being a general inflation captures medical inflation and cost of fuel or other things. But again, I show you this slide not because it will change your thinking about the world of spending drivers, but to sort of recognize that we want to and we need to, and we're working on burrowing much more deeply to have a sophisticated, impactful basis on which to think about spending drivers and which to affect the policy. I'm going to close off with one thought. And I'm sorry, Julie, that I'm going beyond the time that you gave me. And I'll try to keep it still lean. And it is as follows. As we look at healthcare spending over my career, there have been always disruptions. There's the business cycle, in insurance spending, in healthcare spending, but there are also disruptions in policy, the ACA, in economics, recessions, that disrupt sort of these patterns. As I said, one persistent pattern is overall healthcare spending is rising. But I think the other pattern that we're beginning to observe is affordability is becoming a concern for more and more people. We see that in surveys, and we see it just in the calculation, Phil, on what we spend on healthcare relative to people's income. Many of you have talked about extraction of wealth from the community. HR1 will be a tremendous disruptor, and we're trying to understand, to Alex's point, we're trying to understand where and how it comes to play. But the theory of change here is, and why it's important for affordability, for me, goes a bit like this. Fewer people will have Medicaid coverage. Some of them can transition into the individual market. But wait, the individual market, coverage in the individual market, the cost of coverage in the individual market is rising just because of the cost of medical care. And with the loss of subsidies, fewer people will be able to make that transition. There will be a huge cliff for many people. What does that mean? Coverage in the private market becomes more expensive. More individuals will ask themselves, is it worth it? Can I afford it? Why do I do that? Who leaves the market? Healthier, young people first. That changes the mix in the market. That changes the price of insurance products. Typically, there's a lag. People say, I don't have insurance, I don't go to the doctor. That works for a year, works for 2 years, maybe works for 3 years. Eventually, healthcare needs will bring people to the emergency room. Maybe they can pay for it, maybe not. That will affect the infrastructure of a system. Yes, we have very successful corporate entities in the Minnesota market, but there are have-nots, and they're struggling, and access will be affected by it. So as you think about affordability, and as you think about this 2-year timeline, it is so important to keep this transition in mind. And it's our job to be as clear with our expectations empirically as you need them as you think about affordability in the context of the general trends of healthcare prices and healthcare cost growing and that being a burden. I don't think I'm allowed to take any more questions.
Well, thank you. It is a very complicated topic that is challenging to tackle, and we appreciate that you were willing to take it on, and also appreciate all the interest in and curiosity about the data. So it is worth taking this time to do that. We wanted to tee up a conversation for you, and we promised to end on time at 11:30, which we will. So we're just going to tee up this conversation and possibly follow up in between meetings to get some feedback from the task force on some of these issues. So let's go to the next slide. So one of the things that was a takeaway for us from the September conversation was that, and it comes from the roadmap too, where we talked about selecting some priorities to work on in the first part of 2026. Well, how will we select what those are? So let's go to the next slide. There's two parts of that question. So one is, how are we going to pick those priorities? And then the second part is like, well, once you're down in that priority area, having that conversation, how are you going to select among potential policy options? We're going to set that second question aside for now and focus on the first one, which is like, well, how will we determine what are the most important things to tackle in the first half of 2026? So let's go to the next slide. There is a lot at stake, and some of these questions we have already tackled in today's meeting and in September. So, and in Stefan's presentation, sorry. So, what are people paying? Who faces barriers to healthcare? What are employers paying? What's the impact on public budgets? And there's a lot more to explore there. And so, I want to go to the next. The next slide is kind of similar. But it gets a little bit at more of some of the potential policy issues. So these questions that we just talked about which components of spending are growing the fastest and why, and this, is it prices versus utilization and all these other things. We will have more time to get deeper into those conversations. But we've started to have a conversation about, Stefan mentioned, well, market power is one of the things that influences prices. And that's certainly something that has been a rising concern across the country in recent years. What about value-based payments? What about someone over here, I think it was Sheila, brought up all the intermediaries that we have involved in the system and all of those things that play a role. So those are a part of the conversation as well. Let's go to the next slide. So just like we did with the definitions and the values and the principles, we wanted to give you something to react to, which is about, well, what are some criteria that we could apply to this question about how this group will select priority areas? And so some possibilities for the criteria that you could use include things like the size and or the timing of the potential impact on spending. Is it relevant across like all the stakeholder groups? So does it matter to employers and consumers? Or is it just like to certain groups? Is it a system-wide relevance, or is it limited to like people with specific kinds of health insurance coverage? So those are the kinds of factors. Are we looking for like one-time versus ongoing savings? And is this something that policymakers can influence, though recognizing the conversation that we had about the job of this task force is basically about making recommendations about what is the right thing to do. And there's another separate conversation that has to happen about, well, how do you affect this? So Jessica, let's skip over the next slide, which was just an example of what we mean by one-time versus ongoing savings and kind of like what the impacts of that could be. And we will ask you, and can we take 2 or 3 minutes right now to sort of say questions about the criteria for how we'll select priorities, things you would add, subtract, change about that starter list, and what other information do you need in order to feel like you're prepared to start talking about what should the priorities? Marie.
So I have some angst about this. And I think it is this. Your slides were very helpful in defining this. I think this is premature. I don't believe that we have a well-defined problem. And you're going to say, what? Didn't you agree to be on the affordability task force? I mean, I think we have a problem area. But, I mean, I could even make counter just based on everything we've been presented. Affordability is not a problem for most of the people most of the time. Most people are insured. They have been over time. Uninsurance rates have gone down. And I know there's a problem out there somewhere, and I know we're dancing around it, but I don't think we have a well-defined problem statement, if you will, to take action on right now. So that's, I mean, I think it's extremely helpful that we have some information. I will also say that as we think about priority areas and possible solutions, in addition to having a well-defined problem statement, I think we have data, which we need more and more of. So don't get me wrong ever. We absolutely need the data, but data by its nature is backward looking. And I think we have to have an equal conversation about what we think the future into which we're going to place our recommendations is going to be. Because the healthcare system that we have right now is not the healthcare system that we're going to have next year and 5 years from now and 10 years from now. At some point in this, AI is going to become a huge impact on the healthcare system and really radically transform. I don't know how it all is going to happen yet, but for sure it will. I mean, that's an example of a big change coming down the pike. I think, climate change is going to subtly start to impact our health in ways that it doesn't right now, and it will out into the future. And so, again, our recommendations are going to be plopped out into a future that's different from where we are now. So I would just say that I think we have for me, I won't speak for anyone else, I think that we don't have a well enough defined problem statement for me to say what that priority should be.
Andrew.
I think for me, I think there's some additional information I would like to have, which is just this area of wellness. So I was diagnosed 2 years ago with heart failure. But then I lost like 100 and something pounds, and that solved a lot of my issues. But my gym membership, if I'm on a GLP-1, things like that, they're considered wellness. Those are solutions that help my healthcare. And to me, I see it as healthcare because losing all that weight is or solving some of my issues. So if we're talking about preventative care as some of the solutions, then we kind of need to know about the wellness data going on too, because to me that's healthcare, but it seems to be separated from all the healthcare. To me, it's one and the same. I think of my gym membership as
Mike.
Sure. I think, as I looked at the last couple of slides, it feels like we're trending towards reimbursement. Is really the ultimate payer. Who's reimbursing? And one of the things it gets really technical, but just gonna throw out like concept of one price for all. And when you look at where the system where people try to, they've got to get insurance to get a lower price than if they pay cash. And that's a broad statement, but the one price for all, that becomes more of a solution than articulating maybe a philosophy or what we're tackling. So maybe taking that and backing into what's driving that within the reimbursement and the payors.
Last comment, Sheila, before I turn it back over to Alex to close us out.
I wanted to poke on the selecting priority topics area, bullet number 2. I would also like to understand what does relevant mean. So there are dozens, if not hundreds and hundreds of analyses of stakeholder groups and what they think is important around healthcare costs, wellness, sick, I think what you're talking about, Andrew, sick care versus well care. And also speaking to Ellie's role, which is to engage with stakeholders to understand that. But we should also feel, there's a tremendous amount of data and information already out there about what's relevant. I don't know.
Back over to you, Alex.
Thank you for the discussion today. I know we're coming right to the end, and we do want to get in touch with you all after this meeting to just invite a little bit more discussion. We didn't want to curtail it too much, so this is just the beginning of that discussion. So it will be following up with either a forum or maybe some small groups or something. So stay tuned. Jessica, can you go to our last slide? Stay tuned for that, as well as payer and provider recruitment starting next week. We'll be getting in touch with you to help us get the word out. Some public engagement we'll also be in touch with you about, as well as co-chair nomination requests. So all of those things, keep an eye out in your email. We will meet again December 16th. It will be at the Wilder Foundation in St. Paul. And I just want to thank you again for being here, members of the public, and folks listening online. Slides and reporting will be online starting in about, hopefully next week, but we'll get it there. Thank you for your time. Have a great rest of your day.
Thank you very much.